everybody. Welcome back to Val-You Based Care. I'm very excited to have a special guest today, Jessica Everett. I feel like usually I'm maybe a little bit on the goofier side, so I'm going to try to be more serious and important to match my guest, Jessica, here. But yeah, we worked together on PRECEDE, which is the Pancreatic Cancer Early Detection Consortium. And Jessica, I know as a genetic counselor, and you bring a lot of executive and strategic experience just being part of PRECEDE for so long. And my role has been in the community for my practice. I've been a site PI for a couple of years, enrolling a few patients, but really excited that we can talk together about this PRECEDE in terms of an opportunity for patients, just for people in general, to get to know about this. Because I think once they actually know about what PRECEDE is and how it's global, it's really accessible, I think they'd be really interested in finding out how can they be involved or partner in really any way possible. So yeah, thanks for joining. I wanted to keep it open-ended for the first question and just ask in terms of how you think about your experience coming through the world of PRECEDE.
Yeah, I can talk about pre-seed forever. So thanks for inviting me, first of all. And we don't have to keep it super serious. Although, to be fair, pancreatic cancer is a pretty serious topic. So I think, we work on serious things and we try to be serious about work. Um, so I've worked on pancreatic cancer and early detection and genetic testing and counseling for pancreatic cancer pretty specifically for several years now, um, more than 10. And I think that when you spend time working with patients and families who are impacted with pancreatic cancer, you get used to, but never really immune to, hearing the same story over and over, which is my family member was diagnosed with pancreatic cancer and they were gone 3 months later, 6 months later. We didn't even know they were sick, and things went really fast and they passed. And uh, to then be a person who has multiple family members who have had that happen to them, or who carries a gene that we know is linked to risk for pancreatic cancer, is a really scary thing to face. And so that's where the Pancreatic Cancer Early Detection Consortium comes into play. So I think part of the mission, as far as what we want to be able to do for patients and families, is give people hope that we're doing something to improve survival for pancreatic cancer, that there are steps that people can take to protect their health, but also to be part of the effort with clinicians, with researchers who really want to try to change that story so that we can hear more stories like we hear um, from breast cancer patients and families who, now I'll see people who will tell me, 2 generations ago, everybody in my family died from breast cancer, but now we know we have a gene and we're making different choices for screening and for prevention, and people are living longer lives. So we want to try to be able to do that same thing for people affected, families affected with pancreatic cancer. And I think one of the things I really cherish about being part of the consortium is that it really is very collaborative organization, both between the researchers and clinicians across all of the sites that work on pre-seed, but also I really think about patients and families as part of the consortium as well, right? We can't, I always tell our patients and families, we're not going to get anywhere without their help, without them working with us to really try to change the outcomes for this disease.
Yeah, thank you for that very elaborate background. It reminds me about how a lot of times when us doctors are starting out in the cancer world, just training and learning about cancer, sometimes certain cancers or projects in those cancer types can really be a great example of just really the whole entire story and the whole complexity of the universe of cancer. I think PRECEDE does that really well, where it's very much understanding the molecular biology. It's involving people. It's very community, family driven. It's also, it has that interesting angle of doing radiological findings, doing endoscopic findings, combining with blood based testing. And I can think of how, as the field of genetics has been changing, and there's more and more people now engaged in genetic testing and asking about it, you can see that through PRECEDE's history as well. And the maturity of PRECEDE very much is in parallel with that history. And I think now we're in this digital revolution where now we've got artificial intelligence, and I can only imagine how all of that will help accelerate a lot of work that's already been very hard won through PRECEDE, but keep on going forward. And so I'm really interested in thinking, since you are so well integrated into the core values and the strategic mission of PRECEDE, uh, what are some of the things historically that you've observed and now you're taking into new directions going forward that you'd really love patients, doctors, really anyone to come help partner? What are the priorities you're thinking of?
Yeah, great question. I think you're absolutely right that the field that we work in is constantly changing and changing really rapidly. And I think that, again, one of the things that we're always thinking about as a consortium is how can we make sure that we're keeping each other up to date in ways that allow our patients across the US and across the world to really be getting whatever is at the cutting edge of care, right? So, and that includes not just the academic centers, but also community partners, right? Who are going to really be taking care of most of the patients and families that have this family history. So I think that's really important. Um, we have seen a lot of evolution in the genetic space, certainly from being able to test only a couple of genes to being able to test larger panels, testing more broadly, costing less money. And I think we're going to continue to see those things evolve as new technologies become available and we can identify more people who have genetic risk factors that explain what's going on. But I think your point is well taken that that doesn't need to be the only sort of avenue that we're thinking about or place where partnering with patients and institutions could be helpful to answering questions. So I think one area that is has consistently been challenging for researchers and clinical folks and patients to get their brains around is certainly what external influence. So not just environment in the way that we normally think about it, but factors that are outside of us that are affecting cancer risk and how to measure those. And I think those are rapidly growing and changing areas of science that when you have a large consortium like PRECEDE, it can really give us the ability to sort of attract people who maybe didn't think about pancreatic cancer before and bring them into the space to help us try to solve some of these problems. Similarly, we've tried to do things along that line in thinking about AI specifically, you mentioned, and I think one of the things to really pay attention to for patients that I think will be here sooner than later is use of AI to really help us on the imaging side of things be able to perhaps detect things that are just not possible for human eyes to be able to spot. So, one of the things that has really been a challenge for pancreatic cancer is finding things on imaging that are at the earliest possible stage. And I think there's reason to be hopeful that we're going to make progress in that area. And that's a very good, clean example of a situation where we were able to bring some very prominent folks in the field into that space to help us who had never worked on pancreatic cancer before, but were really excited about what we had put together as a consortium and the opportunities that that offers to really try to be able to answer difficult questions and try to solve challenging clinical problems. So, working with patients and families, I think it's there are some challenges there in thinking about sharing data or sharing your medical information. And I think, being able to work with patients to help make sure that we're protecting their privacy and also, answering questions and concerns that people might have, while also making sure that we can um, pull together large enough sets of data for answering specific questions. I think it can be tricky sometimes because there are a lot of things going on with data mining that are legitimately concerning to people. And I think about this more as an AI for good opportunity where we can, clearly see the potential benefit that it will have for patients.
Yeah, and I was just reflecting at how we have this annual meeting where a lot of important stakeholders at the consortium all globally come together. And I was just reflecting how there's so much brilliant work being done, and we share all these ideas really all across the board. So you could be sitting at a table with someone who is a surgeon and they're brilliant at Whipple procedure, and then someone who and does engineering for the AI chips, and they're coming from like Taiwan, and then like someone from Netherlands, and just kind of like wrapping your mind around how there's people all over the world working on a similar goal together, and at the same time running into that struggle of being able to show just the person walking down the street, like where is there risk, how can we look at specific factors and say, okay, you're higher risk, we would want to put you on in one of our study arms, where this is where you would be put into a cohort of similar folks to look at, versus, oh, maybe you're a lower risk and it actually isn't really something you have to worry so much about. Similar to how we, like you mentioned, breast cancer, where there's different scores and different molecular signatures to try to risk stratify folks. And it's very impressive having been to the annual meeting a couple times now, knowing there's that caliber of work and interest all over the world. But it is a very hard, like, can't really seem to crack the code of pancreatic cancer the same way as breast cancer. And it's so much more frightening, like you mentioned, where you hear someone who has it and then just within months, then it's already spread and we're already talking about comfort care. So it's got so many like dichotomies of that. Like on the one hand, we would think that such an aggressive turnover type of cancer, we can derive a lot of data, but it is really hard to take just someone walking down the street and say, this is where we're gonna have you well studied, well placed. And that process is very like I remember at the annual meeting we sit at tables and we try to think very hard about this. And so it really is just seeing the most brilliant minds working really hard trying to think about this. But I also want to, like you mentioned, giving hope, that I would like people to still, even if things aren't perfect in prime time yet, to still approach PRECEDE and ask how they could get involved, whether they can be enrolled, whether their job is even something that could be a part of helping PRECEDE. And so I think it's always very hard for large projects to talk about things like funding, things like partners and trying to garner resources. And funding and resources can also come in the terms of like people, like talent and human capital too, not just like dollars donated. So I'm really curious about the ways we try to pull in and attract all of that energy and combining private and public sectors to work together. How do you think about that in terms of like a strategic map?
No, it's a shifting landscape, as you know. So I think it has been a challenging year um, for academic medicine. And this is, again, largely an academic research effort, a clinical research effort. And we have historically, from the beginning of PRECEDE, have first of all wanted to make the tent big enough that anybody who has a reason to be thinking about their risk for pancreatic cancer potentially can be part of the registry. So we have pretty broad criteria for including people who want to be part of the study. Essentially, if you have any family history of pancreatic cancer, or you carry a gene that we know is linked to pancreatic cancer risk, or you have a cyst in your pancreas that has a risk for cancer over time, there's probably a place for you within the study. And so the study website is PRECEDE, PRECEDE study.org. And there's information, there's links there where people can click a link and send off like, hey, I'm interested in being a participant. A separate link for, hey, I'm interested in potentially collaborating. So we try to at least give people access to get to us if they have something that they want to be a participant, or have other things that they want to be able to contribute um, to the study. But I think from the beginning of the consortium, we really recognized that it was going to be important for us to think about funding in a broad way, and that it was probably going to need to be a combination of things, including traditional grant funding, which is the source of a lot of funding for traditional academic studies, but also that there are big parts of the work that PRECEDE has to do that are not really things that grant funding will easily cover. So, just a quick sidebar for people, grants that we can apply for traditionally through the NIH like to fund the actual work that you're doing to answer a question. And we know in the case of PRECEDE, in order to answer questions, we actually need to build a very large database. And it takes time and money to enter things into that database. We have to collect samples from patients over long periods of time. And again, grants like to pay for you to do things with all the data and samples, but they don't necessarily like to pay for collecting and storing and entering data, which is a really critical piece. So we've known sort of from the jump that there would have to be other ways to try to generate funds that could help us to support the very large infrastructure that's necessary to support 65 collaborating sites and counting. And we're between 11 and 12,000 participants now globally, and headed towards 20,000 as our goal. So that's a lot of infrastructure. So I think, yes, the other types of partnerships are important, both with philanthropy, so patients and families donating their own time and money to the cause, and then also industry partnerships that we have tried to approach as a consortium to work with. Companies in the biotech space primarily, who are doing scientific work that aligns with the goals of what we are trying to do, where you can see that the place they're trying to go is the same place that we're trying to go. So let's work together and with some funding from those types of resources, it can help to support our work and then also help to validate or bring some of these tools that biotech is developing into the clinic to be useful to patients and families. So we really try to think about all of those things. And then from a perspective of people in the community who might have time or talents that they can lend. And this comes up all the time. People who will say, "Oh, I work in PR or I work in whatever area." We've had lawyers who have done pro bono work for the consortium to help us be able to manage things. So I think through our PRECEDE Foundation, which is the nonprofit arm that helps to manage the infrastructure of the group. That's a se- connected organization. That's a great place for people to reach out who might say, I have talents that could potentially be helpful to the consortium and the board, and that group is a great place to bring those. And we certainly have had several people come to us that way.
Yeah, yeah, that's really, as you were talking about that, it painted this really lovely picture of how going back to the thought of, yes, this is on the topic of pancreatic cancer, but it really contributes to the world of understanding cancer in general. That a lot of what is spent in terms of time, the money, the talent, is really understanding so many aspects of cancer because pancreatic cancer oftentimes if it is part of a syndrome then there's other cancers attached to that syndrome or trying to master a, a new AI technology with radiographic findings really could be applied to any type of solid tumors or
Absolutely.
anything that that there's so much branch off and so a lot of
For sure.
ways even though on the face value, it's easy to go like, oh, this is specifically for pancreatic cancer, but really this is a focus of that topic, but expands so much in the realm of understanding, like, where intelligence is not just like little packets, but really it keeps branching out, and there could actually be so many side projects that we could lose
For
focus
sure.
really quickly even.
Yes.
So,
Absolutely,
it's,
absolutely. I was on a call earlier today where that very thing was sort of happening. You get a lot of smart people on the phone who have interesting ideas and questions, and suddenly you're, way off to the left. You didn't think things were going, but that's part of the fun and part of the risk, I think, is trying to stay focused on the goal. But I think you're absolutely right. And it's an important thing to keep in mind that we have many participants who carry a gene that causes risk for pancreatic cancer as one of several things, and probably in most cases, not even the highest risk thing on their list. Um, so, working with we have many patients and families in our database who could help to inform work for certainly other types of solid tumors. And I think a large group of people who are having regular abdominal imaging could be useful for all sorts of things potentially. So we do try to think about those things as long as it's not veering too far away from the original goal. But I think certainly where there's overlap, we want to try to go there. I think the other thing to consider, or that's relevant to that, is that um, the model that we have adopted, or sort of the platform that we have built, I think is a model that you could recreate for other types of cancers to similarly solve problems, right? So I think there's a lot that can come out of what we're doing that could hopefully be helpful for other diseases in that way too.
yeah, yeah, as I understand the history of Proceed as an origin story, I think their database is through Arbor Research, and from what I understand, that wasn't. an easy at all an easy origin. It was almost like one of those venture capital type of stories where it's a lot of risk, a lot of time, many people working very hard with very unsure futures, but just believing in a mission. And
Yeah.
now it's almost unrecognizable to think that there was a time where things were a little bit more just like a few people and more risk and
Ye-
harder to lose, could lose everything you put your
Yes,
investment in. And
all
so
true.
I think that was really just that story itself. There's so much heart in that story. And being able to tell that, I think that would be a very interesting part of talking about Proceed if you ever did like a self documentary. but but yeah, and then to replicate that model that was so difficult to do, but it's easy to take for granted that it was not hard to do, just seeing how big Proceed is now. But learning from all of that and then applying it to other cancer types. I think of especially the young onset cancers now,
Right.
because that has been relatively rare but alarmingly increasing. Similar theme that you mentioned, where we're not really sure what are those external factors, but it doesn't always seem to be genetic either. And
Right.
we get the feeling that somehow it is our industrialized world and the way that we live now that's different. And so I think of if there were other ways for Proceed, where Proceed is like a hub, and then you get these branching spokes of other, like, young adult, like colorectal or lung, or just these other models of built-in challenges. Like pancreatic is challenging in that it seems to have a uniform genetic landscape, and yet it's so hard to target and
Right.
so very aggressive. And then finding these sort of like unique, what is it unique about each cancer, and then creating these types of global
Right.
consortiums. Very hard to do because I think everybody's got their own lab too, their own project, their own
Exactly.
way of looking at it. So I think of Proceed as sort of like the diamond in the rough, or the hidden jewel that a lot of people probably don't know about. But if they did, they'd be rushing in to try to join forces, or even create their little spoke of, oh, I'm more young adult colorectal, but I could learn from Proceed and build off of that.
Yeah, for sure. And I think, as again, just kind of tying into the young onset cancers, this is another, I guess, sort of example of how Precede has said, okay, we were focused pretty hard in this direction, but this is also potentially a way to go that is interesting and fruitful. We, initially built the whole thing around screening. So people who come in healthy and who are being followed over time, and a lot of the sites who runs a screening program, maybe that's all under gastroenterology. And once a person is diagnosed with cancer, they go someplace else to get their care. And, that's kind of the end of them. They're not part of screening anymore. And we have really had to start thinking more seriously about, well, there's actually a lot we need to learn from that participant who may have been followed for an extended period of time and then developed a cancer. That more in-depth analysis of the biology of that cancer, of markers, in the blood before that cancer developed, changes in their imaging over time, and then also monitoring to see how those folks do so that eventually we can prove with data that finding these things earlier in their trajectory is actually making a difference in people's long-term survival. And as part of that, so, now we're spending a little more time thinking about how do we collect tissue for these cancers and how do we collect matched blood for these cancers. And then once you start thinking about pancreatic cancers and collecting things, then you start thinking about, well, what other pancreatic cancers would help us learn more in the context of PRECEDE? And certainly that includes people who have pancreatic cancer and maybe from a high risk family, but were not having screening. So they got their diagnosis and have a BRCA2 mutation. They weren't being followed before that diagnosis. But again, I think a lot we can learn from those cancers, from any prior imaging they might have had, and then people who are young at the time of pancreatic cancer diagnosis. So that is one of the cancers where early onset disease is increasing for reasons that people don't understand, but that does not appear to be related to the genes that we know about, related to risk. Um, One of the many ways pancreatic cancer can be challenging is getting tissue for doing sequencing analysis and all of these sorts of things is trickier for pancreatic cancer than it is for many other types of cancers. The pancreas is deep in your body, so getting a biopsy is not a trivial thing. You may get a very small amount of tissue at the time of biopsy. And then one of the big things that we run into is that when you biopsy a pancreatic cancer, it turns out that within a pancreatic tumor, and you know this, but I'm saying it sort of for the benefit of everybody else, often there are not that many cancer cells within the biopsy itself. So pancreatic cancer is kind of an unusual tumor in that there's a lot of stuff in the tumor that is sort of connective tissue kind of stuff. It's not cancer cells, but sort of an extracellular stuff that gets produced. So that's a highly scientific term. So my point just being, it can be really difficult to analyze pancreatic cancer even from a biopsy. Many patients may not have surgery until after they've had chemotherapy. And again, then hopefully there's not much tumor left. So my long way of getting to the point here was that a consortium effort can help you to say, well, if we are all trying to do this, then perhaps we can get a pool of enough cases of early onset pancreatic cancer where we have some tissue that we can actually do something about it versus any one site who may see, a handful of patients diagnosed in their 30s and 40s and only be able to get tissue from, one or two. So there are things you can do together that are just going to be harder and take longer if you try to do them alone.
Yeah, it definitely is. It speaks to the power of being involved in a network, or definitely one person is, it's very hard for one person to thrive. And even if you think of it like uh, a few people, that's still very difficult. But when it's an entire global network and everyone's connected, and there probably still are some folks who are doing their own form of research in the pancreatic space, and being able
Absolutely.
to let them know, well, if they wanted to be part of PRECEDE, that would be wonderful. No one's gonna, of course, force anybody, but I think sometimes people just don't even know. Like, if they knew, they'd be like, oh yeah.
Right. Yes. And I think we are, doing some things, and this is certainly part of the something, right? To try to make sure that more people know about what we're doing. I think hopefully, as far as other people who are working on pancreatic cancer in a research capacity, um, we're starting to get to a point where the data is getting more mature, and I am hopeful that we're going to start to see more presentations at the kinds of research conferences where people who do pancreatic cancer research will be. And we'll be able to hear about what we're doing and see what we're doing. And that's often, certainly historically, how I've learned about those kinds of efforts, right? Is at a conference where somebody gives a presentation and says, hey, this is what we're doing. And here's how to find us if this is of interest to you. So I think um, I expect that we're going to start to see more of that over the coming year, which is very exciting.
Yeah, and I think very much that it's not for lack of trying to outreach, but like you mentioned, screening is such a hard scientific methodology, like trying to prove that you caught something and that because you caught it early that led to an improved overall lifespan without
Right.
introducing biases like oh it was just it was going to happen anyway and it was
Exactly.
just by chance.
Right.
So
The trajectory would have been the same and you just found it here instead of here. Yeah.
yeah, yeah, so that makes it so much harder where it's not for lack of trying, but just the problem is so much more hard to Rubik's Cube.
Right. Right. For
Yeah,
sure.
yeah. But I really appreciate how much time you're spending talking about the depths of this because I feel like patients don't really get to hear a lot of this. And that's really the thing that I feel like when I'm out in the community, patients are gravitating toward this, like, oh, if only I knew. And I think of it like a real achievement, a scientific achievement when they're really curious about genetics because it's easier, I feel like, to get afraid and cynical. I feel like that's a very natural more common reaction to things that we don't understand. But I find in the community, patients want to ask more about, like, oh, this bad thing happened to my family member, and I heard there's research. Like, how can I help? How can I be involved? And so I'm very interested in how to engage more of the advocacy side of getting folks.
That
Yeah,
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 that is, I think, a point where we have not fulfilled the mission as much as I would like us to. Um, Partly, I think, and this is not an excuse, but partly just due to having the boots on the ground to be able to follow through on these kinds of things. Pretty much from the beginning of Precede, we have thought like even just basic things like it sure would be nice to have a newsletter, like something that is patient oriented or not even I keep using the word patient interchangeably with just, people in the community who are not healthcare providers or researchers. Um, but something a layperson could read that would tell them about what we're doing in a way that people could understand, that might come out once or twice a year with some updates about what's going on. I think that kind of thing is terrific. And I would love to see that happen in the next year. And like I said, it's been a goal from the beginning 5 years ago, more than 5 years ago now, but I'd really like to see that go someplace. And I think we have certainly had conversations with advocacy groups, both in the pancreas specific space and also for gene carriers. So the Force organization, which is terrific for people who have inherited risk for cancers in their families, have had folks from these organizations invited to and attend our annual meeting. But I think like we've only scratched the surface of, okay, we're connected, we have a relationship, but we haven't necessarily taken things to a next level. We had, again, a grant opportunity that didn't get funded that would have included, sort of regular advisory meetings with those kinds of groups to talk about what we could be doing together. So I'm hopeful. There's also within our governance structure for Precede, a committee that is really designed to try to address some of those points that kind of fell apart for various reasons, but is coming back together and re-energized. So I'm hoping that that may also lead to some more direct attention to, I think, this is a really important thing that I think we could be doing better. And I hope that we will in the year coming up.
yeah, I think that in every site, as you've mentioned, there's over 65 and growing all over the world. that if anyone approaches any of us site leaders, I think, and this is something I need to do better at, and I've recognized, is that when there is interest, trying to carry that momentum immediately and figure out where should that interest go. And it may not be immediately what a person's thinking. Like they might go, oh, I want to enroll into one of the cohort arms, but maybe they don't match all the criteria. And so they may actually feel kind of like discouraged and
Mm-hmm.
disengaged. So I think coming up with a way where once people show interest, feeling like we're very appreciative of that, and even if they don't get that first goal, but then how do we tuck them in still? And I
Right.
think that part, of not losing the engagement as it comes,
Yes.
I, I'm trying to figure that part out as a site leader, because that having those patients, I think it also comes down to communication skills too,
For
which I
sure.
feel like I can always be working on and improving. As a doctor, it's very easy for me to talk more scientific, logic based, but they're coming with an emotional story in mind. And
Absolutely.
there's probably
Yes.
something like their family member or something they're really afraid of.
Yes.
And oftentimes I reflect, probably they had a need and I didn't really identify it, even beyond the ARM enrollment, but like maybe they wanted to
Right.
volunteer. And so I'm trying to work on those skills, which I feel like as a genetic counselor, you probably feel like that's just your bread and butter skills of being able
Yeah,
to,
no, I
yeah.
like hearing you say that because I think it's so important and something I try to talk to our trainees about too, that there's sort of like the risk that we scientifically think somebody has, and then there's the risk that somebody feels like they have. I've seen examples of this over the years where a patient years ago who was really worried about breast cancer, and it was like, like her child's teacher had it and her neighbor had it. And so there was like all these people in her sphere who were affected, and it suddenly felt like it was all around. Um, and that's real. It might not have anything to do with her risk, but it certainly has something to do with how she's feeling about it in a way that led her to reach out. So I think your point is well taken that when people come to us, sometimes they're very happy to hear, like, actually, no, nothing that you need to do right now. And that can be a relief. And other times, I think you're right. That might be disappointment isn't the right word, but maybe they want a little bit more. Even if it's just like, I want to be on the mailing list for your newsletter so that I know about things that are coming up, right? Like that might be a nice way to be able to keep people to make people feel like we have heard you and taken your concerns seriously and want to keep you in the loop.
Yeah, so for the value-based care audience, if anyone wants to volunteer to work on the newsletter. But
Soliciting good writers.
yes. But yeah, and I know it often gets dismissed as a soft skill to help someone feel understood, but I think when we have had that happen, like we know what that feels like when we go, okay, this is really not based on logic, and I know that what I'm feeling is very much centered on something that maybe someone else won't really feel the same way, but it's really important. And I think being able as an oncologist or oncology providing uh, caretaker, and especially someone who does extensive communication like genetic counseling like yourself, I think that having a priority of allowing people to feel heard really is a benefit for us scientific minded people because it opens up our curiosity. Like you, whenever someone says, "Oh, my like teacher had this cancer and then my friend," and then it's on one hand maybe one could go like, oh, that's not related. But on the other hand, you can then go, oh, well, maybe this is environmental, or maybe something that you're picking up on, we need to really delve a little bit more. Maybe not, but having the ability to try to help someone feel understood really helps the scientific ingenuity. Like I don't I don't think of it like there's some one smartest person in the world. I think it's more our ability together as a community to pique each other's curiosity and keep asking these ever elevated questions just by listening to each other's fears. And then we know that we're onto something when someone starts feeling heard. So
Yeah, absolutely. I think
yeah.
it's really hard to get anywhere with not just in interactions with patients, but in interactions in any setting. It's really hard to get anywhere if one side of a conversation feels like you're not hearing what I'm saying. You're not listening to me where I am.
Yeah, and I felt Proceed when I first heard about it and thought, how did I not know that it was this great marriage between the so-called the soft communication skills, which really is not soft, and then that hard science of how do we find that holy grail and break into the screening, early detection side of things that is so hard, so elusive for many cancers. It really have to be at least trying, maybe not masterfully good
Mm,
yet for me,
mm,
but at least trying in both ways, like holding both, and it
yes,
makes you better at both when you try. So I really
agreed.
love Proceed in every way. Everybody just come join.
I
Yeah.
agree with you. I love being part of it. It's a fantastic group of people who, as I said, take work seriously, but also we have a lot of fun at our meetings too. So I think that's important.
You. Yeah. And then the annual meeting, there's the dancing part, which
Exactly.
I admit
Yes.
the first year I got scared. I kind of hid. But the second year I danced. I really
Perfect.
like the Britney Spears and the Spice Girls. So
Absolutely. Perfect. That's what we want to see again. It's evolving. We all evolve over time. Getting
that's how
more
you
comfortable
know.
with the group.
Yeah, yeah. You gotta not just be a good researcher, but you have to have like some street cred. Like you have to be good
Absolutely.
at street cred too. Yeah, yeah. Well, I feel like this was such a full, amazing conversation, and I'm really curious what will happen when folks start listening in. So I really appreciate your time, Jessica.
Absolutely. It was lovely chatting with you.
Well, I just wanted to say thank you to the whole audience too for watching Value Based Care once again, and I'll catch you all at another time.